Good evening, everyone. A warm welcome on behalf of Shield Healthcare. I'm Dr. Prachi, and thank you very much for joining today's webinar. This webinar is brought to you by OGSSI Public Awareness Committee and Midlife Committee. It is about the perimenopausal story, and I'm very happy to introduce today's conveners, Dr. Sumati Premanand and Ma'am is a medical director, Darshan Fertility and Women's Medical Center, and Mind Cafe, which is a center for holistic healing. Executive Committee member, OGSSI, coordinator of Public Awareness Committee, FOXY, Master Trainer, Dhira, and No to Violence Against Women, FOXY Committee, State Council member, IMA, co-chairman of Women's Doctors Wing, IMA. She is poet, avid traveler, and Tamil enthusiast. So welcome, ma'am, and thank you very much. Our another convener is Dr. Karpa Gambal Saira. Ma'am has special interest in fertility, high-risk ops practice, and gynec endoscopy. Recipient of AICC RCOG Traveling Fellowship in Gynec Endoscopy. Executive Committee member of OGSSI. She had presented many papers in national international conferences and won many prizes. Consultant at Sri Sai Specialty Clinic, Kaveri Hospital, and Nova IVF Fertility Center, Chennai. And ma'am has hobbies of running and riding. So welcome. I welcome you, ma'am. So with this, I hand over the sessions to Dr. Karpa Gambal, ma'am. Over to you, ma'am. Thank you very much.
Good afternoon, everyone. A warm welcome on behalf of Public Awareness Committee and Midlife Committee of OXY. Thank you, Dr. Prachi, for giving us this very wonderful platform time and again. Now, let me tell you about this perimenopausal story. After the big, super duper hit of the Ponniyin Selvan 1, we thought we'll just have something similar. So we called this a perimenopausal story, part 1 and part 2. The most common complaints our women come with, I'm sure men must also be having these kind of issues, apart from the hot flashes, but the most common thing is sexual dysfunction or decline in sexual function, decreased libido, sleep disturbances, and hot flashes. So they are not able to find out any medical reasons for it, but they want to explore the reasons why at this age, in the middle age, many women are facing such kind of issues. So for this, we have experts in their respective specialties to talk and enlighten us about these three major aspects. They all know that it's not a major problem, but it's actually affecting their quality of life. A lot of marital disharmonies are there and a lot of disturbances are there in the families. So we thought we'll address this issue on a larger perspective. And we have invited three eminent personalities who can really give us a great idea about us. We can counsel our patients and take care of our patients very well. Now, I introduce our, please, next slide. Now we start the program with our Tamil Thai Vazhthu. Now we have the traditional lighting of the Kuthuvalakku, which is the most auspicious occasion for any beginning. Now, I would like to introduce our dynamic president of Oxy, Dr. Jairani Kamaraj. Madam needs no introduction at all because Madam is actually everywhere. She's all around and taking care of so many things, so many feathers to her cap. Actually, she's a consultant of reproductive medicine, infertility and sexual medicine, and director of Akash Fertility Center and Hospital, Chennai. She's at present the president of our society, our most dynamic president. She's a treasurer of Tapisar, and she's associate secretary, World Association for Sexual Health Advisory Council Committee and World Association for Sexual Health. And Madam has a lot of medals and awards to her credit. And most importantly, Madam has been an outstanding president so far, and I'm sure she will really do justice for the job that position she has taken up. We welcome Dr. Jairani Kamaraj to this webinar. Next, I have the great pleasure in welcoming Dr. Kundavi Shankar, one of my mentors whom I can never forget in my life. She is the head of the department and senior consultant at Madras Medical Mission, Institute of Reproductive Medicine. She's a renowned national board certified obstetrician and gynecologist. And Madam is trained in ultrasound, andrology. She is an active member of Oxy, IMA, ISAR, and Tapisar. And Madam has a PhD to her credit, and all the journals. We have so many candidates from IRM who are doing very well academically. And thanks to Madam for her mentorship. I welcome Dr. Kundavi Shankar to say the Oxy prayer now. Next slide.
Thank you, Karpagam and Dr. Sumati. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with blessings. To pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it when all things are not perfect. And to remember that we are but the messengers to keep our women safe, free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, ma'am. Now, I hand over the proceedings to Dr. Sumati Premanand, who is a co-convener henceforth. Thank you.
Thank you, Karpagam. Thank you, ma'am. Today has been a very busy day and a lot of activities are happening both in the Foxy side, IMS side, and in Oxy side. It's a very busy Saturday. Can we have the slide, please? I take great pleasure for having convened over here in quite a large numbers, despite many programs which are going on simultaneously. I thank all the faculty and all the delegates who have joined in. I thank Chitrakala, who is from Shield Pharma, and the entire Shield Pharma for giving us a shoulder always to, whenever we need webinar, all we just need is to do a phone call and they are there to do the entire program, and that really helps us a lot. Thank you, Karpagambal, for giving a great shoulder on this too. And I am so thankful for the chairpersons, Dr. Pranjal Charaswat Sharma and Dr. Priyankur Roy, who immediately consented once we said we are going to come in with a very small program, but which is a very focused program, because the idea of this PS1 is basically to bring in enthusiasm and curiosity, to plant the curiosity in people who are going to watch this, basically because all of us, including doctors and patients, are searching for endless answers regarding PS1. The PS1 is now consisting of the problem in the perimenopausal age group in sex, sleep, as well as the tiresome and a very difficult, hot flushes. So we thought we will focus on these, and I'm so thankful that our chairpersons consented. They are very, very busy people. With great difficulty, we got them in. They are still, I think they must have logged in by now. They just called me. Can I have the introductory slides of the chairpersons, please? Dr. Priyankur Roy is the assistant professor of Lord Buddha Koshi Medical College and Hospital. He is very well-known person in the Foxy level as a chairperson of the Public Awareness Committee. I belong, to his I'm one of the coordinators of Tamil Nadu chapter of Public Awareness Committee. And he is a vice president in a lot of organizations. And he is an invited faculty in many international and national conferences.
Ma'am, it's okay, ma'am. Thank you so much.
Oh, yeah, come.
Okay.
I was just waiting for you to come in.
Thank
you so much. And thank you so much for coming in despite your schedule, Dr. Priyankura. And I wish you could stay back completely for these. We have kept it very short, 20 minutes for each and 3 to 5 minutes for interaction. And each interaction will finish as soon as the particular topics are over and the questions will be addressed and your expert comments are needed from the chairpersons. Can I have the next slide, please? The next slide, please. Dr. Pranjal Saraswat Sharma is the director of Sharma Hospital in Amravati. She's a director of RIMS Amravati and was a zonal coordinator in AMOX till 2022. She is an organizing secretary of AMOX and is a state IMA vice chairperson and is a recipient of many awards and is a faculty in many state, national and international conferences. Thank you for joining us, ma'am. She should be joining us shortly. Now I request the Dr. Priyankur Roy to introduce the speakers. We start off with first Dr. Deepa Thangamani because our president is held up in a meeting. She is simultaneously taking over at this point of time as an executive committee member of IMS. As soon as she takes over, she will be joining in. So we just switched the topics and Dr. Deepa Thangamani would be talking first on flush the hot flushes. I request Dr. Priyankur Roy to introduce her. Next slide, please. Dr. Priyankur, you have to unmute yourself, I think. Yeah.
I did, ma'am. Yeah. Thank you so much. Good evening, everyone. It indeed gives me immense pleasure to be among all of you today in this excellent webinar of the Chennai Society, that is the South Indian Society, the Public Awareness Committee, and as well as the Midlife Committee. And as ma'am has very aptly introduced the perimenopausal story, part 1, with the theme of sex, sleep, and hot flushes, which are the most important things that we see probably in Indian women, since we know that they suffer orders, which definitely needs to be discussed and brought out so that our women can be treated for the betterment of women's healthcare. So I would like to first of all thank Jairani Kamraj ma'am, who's such an active member of the Public Awareness Committee, the national body, as well as she is the Public Awareness Committee chair of the Chennai Society as well. So thank you so much for this opportunity. And now I would like to introduce the speaker for this topic, Dr. Deepa. Dr. Deepa is going to talk to us on flush, the hot flushes, a very nicely coined term, I must say, for the topic. She is a consultant at the Apollo First Med Hospital in Chennai. She is a consultant at the Tamarai Fertility Solution Chennai as well. And she currently holds the post of Joint Secretary at the Association of Tamil Nadu Members of Royal College of OBGYN and the Joint Secretary member of the Chennai Obstetric Society. Her areas of interest are gynae endoscopy, emergency obstetrics, and ART. So with this brief introduction, and of course she's an examiner for Part 3 MRCOG as well. So with this brief introduction, I would like to hand over the stage to ma'am for her talk on this important topic of flush the hot flushes.
Thank you. So, are you seeing my screen? Thank you for the kind introduction, Dr. Priyankur. Thank you so much. And it's my pleasure.
So much,
are you able to see my screen?
Yes.
Yeah, we can see it, ma'am. Please make it full screen and then
yes, full screen.
Thank you.
Yes. Okay. So thank you so much. And my topic is like vasomotor symptoms, which call hot flushes. So this was the most common symptoms people in the perimenopausal age groups will be coming to the hospitals. This is the one of the most common symptoms they will actually find for coming for the treatment. So what is hot flushes? So it contains 3 components, like we have hot flushes, cold sweats, and night sweats. Is a subjective sensation of the heat that is associated with the objective signs of cutaneous vasodilatation and the subsequent drop in the core temperature. So it begins in the upper chest, neck, and spread to the face. So associated with redness and sweating, and they will be drenching in sweating. So the sweating is almost, they can't do anything. And just now they have taken a bath kind of sweatiness. And the average flush loss between 30 minutes, 30 seconds to almost 5 to 6 minutes. And the skin temperature rises 1 to 3 degrees Fahrenheit during the flush, and the core temperature falls slightly, associated with an increase in metabolic rate and the heart rate. Almost there is a palpitation of 7 to 15 beats per minute. So this is what happening. So initially the core temperature increases, skin blood flow and heart rate increases, and increased feeling of head in the upper body. And then finally there is an increased skin blood flow and vasodilatation and shivering. They are shivering, drenching. At the same time, they will be sweating. So this is a whole heart flash scenarios the people will be having, and typically occurs in the perimenopause and then decline over the months to 2 years. For some people, it may persist. It may be a long durations and may even persist 1 to 2%. It will persist all through your life after menopausal period. So how early it will start? For suppose if it is starting less than 44 years, if the heart flush is starting less than 44 years, it is found that they tend to have a long duration of heart flushes. If it starts more than 44 years in the actual menopausal periods, maybe they will be having a short term. So the frequency, my PMS lasted for 7 years during the menopausal transition for more than half of the women and persisted for 4.5 years after the final. This is an average 4.5 years after the final menstrual period. So women undergoing for surgical menopause develop distressing flushes. It's often not established at the time of discharge, but some people even before they are getting discharged, they started having heart flushes, mood swings, sleepless, insomnia, and sweatiness during the time of discharge and up to 6 weeks later. So what are the risk factors? The main risk factors is the ethnicity. The main risk factor is the race and ethnicity. So those who are an African and Native Americans have highest risk compared to the Japanese, Canada, and Chinese and North Filipinos. They will be having a very less risk factors for, they won't be getting, even they won't go for a premature ovarian failure also. So there will be an abrupt menopause symptom. Surgical menopause are so abrupt and severe and can even last longer than those with the non-surgical menopause. So those who are already having a PMS kind of feeling, mood swings, irritations, bloated feelings during a younger age groups, or those are really having a depression, they will be having increased risk of getting heart flushes. And for them, the heart flushes may persist all through the menopausal age group. What about the BMA? BMA is having a direct relationship. Those who are obese, of course, they have a heart flushes. The problem, the one thing about obesity is initially they will be having a heart flushes. They have an increased risk of getting heart flushes. But over the time, in postmenopausal period, the obesity may be a protective fetus. So later on the age groups, they won't get much of heart flushes. The transitional periods, they will be having more prone for heart flushes. And temperatures, if you are there in the warmth, or if there is no AC, if there is no air temperature, they will be prone for heart flushes. Timing is usually in the perimenopausal age groups can cause as early as 43, 44 years, and then decline over the time of 6 months to 2 years. And the SWAN study found that the peak of heart flushes occurs in the late perimenopause and early menopause. Frequent VMS lasted more than 7 years during the perimenopausal transition for more than half of the women and persisted. Okay, so I'm just coming to the same thing. What are the risk factors? I said the ethnicity. And the risk factors is mainly obesity, African descent, low socioeconomic effects, and their genetics. What about the genetics? The most genetic problem they will be having is they found out that there is a single nucleotide polymorphisms in the intronic regions of tachykinin receptor 3 genes, which codes for neurokinin B neuropeptide receptors that significantly associated with menopausal things. And that the problem the biochemical mechanism account for this, the problem in the thermoregulation in the hypothalamus. So it's triggered by the core temperature elevations acting greatly narrowed thermoneutral zone. See that the zone for which they are having the hot flushes will be very narrow in postmenopausal women with hormone with hot flushes. So when the two estrogen is the most culprit. So the following estrogens affect the thermoregulatory centers and controls vasodilatation sweating. At the same time, it also the withdrawal causes increases the serotonin levels, serotonin receptors that increases the serotonin levels in the hypothalamus and decrease in the endorphins, norendorphins, and serotonin release, lowering the thermoregulatory thresholds and hot flushes. So directly it affects the thermoregulatory zone, and as well as it indirectly affecting the serotonin and receptors, causing the release of endorphins, norepinephrine, and serotonin release, lowering the thermoregulatory threshold, thereby causing the hot flushes. So, do you think the estrogen deficiency alone reasons? That means estrogen replacement usually treats us. Is there any other factors? Oh, clonidine alters the estrogen levels. Why prepubertal girls doesn't have much of estrogens, but why they don't have hot flushes? So there is some other genetic factors, not only estrogen withdrawal. So some other genetic factors plays genetic as well as factors evolving in the menopausal age groups causing that hot flushes. So what are they? Normally, luteinizing hormones and luteinizing hormones have an effect on the, because of GnRH luteinizing hormones, hot flushes occurs. So what happened in LH suppresses the GnRH compounds. Women with pituitary insufficiency, hypoestrogenism, hypophysetemia women have hot flushes. So mainly that opioid antagonists have and hot flushes have an inconsistent results. So norepinephrine, dopamine, and serotonin have the plays a major roles along with the estrogen deficiency. So elevated brain norepinephrine in conjunction with estrogen are part of etiology of the hot flushes. And there is now recently found out that kisspeptin neurokinin dynorphins KNDY genes. What is that? The thermoregulatory center in the brain hypothalamus is innervated by this KNDY neurons. These neurons are stimulated by the neuropeptide neurokinin B acting at the receptors, which is inhibited by the estrogen. With its declining estrogen levels during menopausal transition, this neurokinin 3 KNDY neurons have been leading hypertrophy, thereby altered activity in the thermoregulatory centers. So other genetic things they found out is calcitonin gene-related peptide, which is localized to the sensory fibers. It is the most potent vasodilators in the man. So intravenous CGRP causes greater increase in skin temperatures of overactomized rats compared to controls. The vasodilatory effect of CGRP is independent of histamine, bradykinin, and prostaglandins. In fact, hot flushes do not respond to antagonists of any of these substances. So cutaneous distributions follow the distribution of sensory nerves, which can explain why flashes predominantly affect the upper torso, chest, upper chest, back, face. So this is found in the cholinergic sympathogenic nerves of the sweat glands, and local administration of CGRP enhances methacholine-induced sweating in a dose-dependent manner. So these are the two things they have identified. So why I'm telling about this KNDY, now the newer drugs has been, other than the HRT, the newer drugs have been identified to target this KNDY neurons for the treatment of hot flushes. So with this, how will you assess the hot flushes? There are 3-4 index scores have been was there. One is the Kupperman menopausal index. The other one is green climactic scales, UTN scales, and the menopause rating scales. What is the hot flushes scores? Well, they identified the severity scores depend upon the number of hot flushes in a day into 1 plus number of moderate hot flushes into a day by plus 2. They are given a marking of 2 plus number of severe hot flushes per day into 3. So this gives a score of highest scores indicates worse symptom. There is no maximum score. Since the score is patient dependent for both the number and severity. This is simple hot flushes scores. Then there is a menopausal rating scales where they have a rating from 0, 1, 2, 3, 4 for none, mild, moderate, severe, very severe categories of hot flushes. So from that they will be grading the hot flushes. And what is the green climatic score says? Here they assess the 4 subcontinents. One is psychological. They give the scores of between 0 to 33. Somatic like aches and pains, joint pains 0 to 21, and vasomotor symptoms 0 to 6, and sexual 0 to 3. So the total score they can range anything from 0 to 63. Higher score indicates the worst symptoms. For the vasomotor subscore, a score of 0 to indicates no mild heart flashes, 3 to 6 indicates moderate to severe heart flashes. And what about modified Kupperman? Modified Kupperman, they have taken the 11 subcomponents: hot flashes, sweating, insomnia, nervousness, depression, vertigo, tiredness, joint ache, headache, palpitation. All are scored between the scoring between 0, 1, 2, 3 strong, and the total scores 0 to 51. Highest scores indicates the worst symptoms. So when woman presented with heart flashes with this assessment, first and foremost is like we have to take a proper history, because we rule out any trigger symptoms, any drugs causing, any diseases causing heart flashes, like what are the diseases which is autoimmune deficiency symptom, tuberculosis, thyroid diseases like hyperthyroidism, mastocytosis, all the systemic diseases, and medications like calcium channel drugs which is causing premature menopause, cholinergic drugs, ketoconazole, opioids. And once you ruled out, take a proper history, symptoms, be the vaginal smears and vaginal pH going for, and look for serum FSH estradiol inhibin to the indirect markers for the perimenopausal transition, and trial of medication like progesterone withdrawal and HRT. So with this background, we'll go to the management. If it is a mild heart flashes, then you can modify the daily life mild subtleties, like use of fans, lowering the room temperatures, and ask them to avoid spicy foods, take a well-balanced Mediterranean diet, use of clothes which are heat and sweet friendly, and maybe vitamin E in low doses, weight loss, cognitive behavior therapy. May not be very good in heart flashes, may be good for the depressions, but here still weight loss and cognitive behavior therapy may help for mild heart flashes. So what are lifestyle changes? Most of the relaxation techniques like spaced respirations, decrease central sympathetic tone, reduce the heart flash intensity, anxiety, tension, and depression. Exercise, is there any role? The studies of SWAN study have found out that there is no beneficial effect on heart flashes. Exercise, in fact, raises the core body temperature, thereby triggering the heart flashes. Practices like AC, keeping cold showers, dressing in layers, ingestion of cold food and beverages may be helpful. And stress management, relaxation therapy may not be effective. Meditation, smoking, weight loss may be helpful. So, moderate to severe will not go with your lifestyle management. Here you need whatever the withdrawal estrogen is there, we need a withdrawal treatment. So first and foremost, estrogen therapy is the hallmark of treating the heart flashes. And you have other non-hormonal therapies like non-hormonal therapy like plant estrogen, as well as medications like SSRI, SNRIs, and clonidine, and gabapentin, paragabapentin. And HRT benefits both both heart flashes and symptoms. So what is your route of giving? One is like transdermal route, subcutaneous implant, or vaginal, or traditional oral therapy. If they intact uterus, you have to combine the estrogen and progesterone. If there is no intact uterus, you can directly supplement with the estrogens. Start with the lowest dose and slowly increases. If the risk assessment shows there is a high history of thromboembolism, then you cannot give a oral estrogen. So you have to go for a transdermal alternative pathways. Start with a low dose and slowly increases for severe hydroxis, increases the dose. If there is an intractable heart flashes, then you may have to highest modifiable doses you have to give. Once they are happy with the dose, then you can continue with the source. So even with the highest doses of estrogen in an is unsuccessful in stopping the heart flashes, you can stop. The people will be complaining. See, you were giving the highest dose, but they will keep complaining. No, I'm not getting benefit. I'm not getting. Ask them to stop it for a while, then restart at the usual dose. If you're stopping it for the while, the people will be getting more heart flashes. Though then they will be happy with the dose we are giving. So then when they come with again with they will want to start. They will start the same dose. Then they will be effective. Women give a chance that they compare the severity of heart flashes on and off estrogen. She may decide that although hot flashes have not completely disappeared, estrogen is beneficial. She may tolerate the residual dose. Then Suppose if they are taking another antibiotics or any hepatic enzyme activity induces, then ask them to stop it or decrease the drug dosage and replace the drugs which is causing a problem with estrogen absorption. Or you change the route of estrogens like transdermals. If it's still intractable hot flushes, then you have to rule out malignancy, hyperparathyroidism, and renal cell carcinoma and infections. And these are the estrogen and progestogens. Suppose for the inner patients with the progestogens may not be helpful for people. They may be having bloated PMS, depression. So the progesterone component, we can start with the component of besidoxifene. The advantage of besidoxifene is that those are personally cancers, then besidoxifene have been safe given. So along with the conjugated estrogen and besidoxifenes, we can give they will be benefited. It has an agonist of an effect on a bone as well as antagonist effect and rheumatism, no effect. So it will help for their osteoporosis. They can go for a long-term treatment also. So how long we will be giving? We give a maximum duration of 5 years or up to reach 60 years. The HRT can be given 50 to 60 years safely. So it can be stopped in 40 to 50% within 1 year. You can stop, and 65% we can stop altogether. Once a decision decision has been taken to stop HRT, so you have to taper the drugs for over the 3 to 6 months. Recurrent heart flushes, non-hormonal treatment options are used first, followed by the extended HRT. What are the non-hormonal treatments? First and foremost is tibolone. Tibolone reduces the heart flushes when compared to placebo. It additional benefit on bone. It has a sexual dysfunction. It has a moderate effect, and it has a weak estrogenic, progestogenic, and androgenic component. So coming to the isoflavones and botanicals, the studies have been found out this plant-derived compounds to treating hot flushes have no significant effect. So this is the study. So compared to the placebo, only HRT reduces the hormone therapy reduces the thing. Black cocoa, malted botanicals, or soy proteins. None of this is not more happy than the placebo treatment. So cognitive behavioral therapies, as I said, benefits distress and sleep problems, but effect on heart flushes per se is not certain. So because of the heart flushes, sleep and disturbances, maybe Dr. Ramkrishnan will be sleep problem without any proven benefit. Then the stellate ganglion block alleviate heart flushes, especially to the moderate. Those are not able to use estrogen therapy, and they are intractable heart flushes. We can go for it. And acupuncture study, this is a very relatively small studies. We need a large samples. It shows that there is not much of effect. Clonidine is a one. It's by widening the thermoneutral zone, thereby decreasing the heart flushes. There are 2 placebo-controlled studies states that it reduces the heart flushes by 46% to 80%. Okay, 2 studies of breast cancer survivors receiving tamoxifen showed smaller but significant reduction in heart flushes frequency of oral and transdermal clonidine. Serotonergic drugs, paroxetine, see, these are all these drugs, SSRI, SNRIs, have been since 2013 only is FDA approved for this use for heart flushes. Before that, it was not FDA approved. So the drugs of choice is 75 milligram daily. So probably low dose. No need for tapering the dose when you're withdrawing from that. Escitalopram 20 milligram daily. Fluoxetine, sertraline is not found to be very effective. And when you use fluoxetine, paroxetine, so probably when you are on tamoxifen, it will interfere with the tamoxifen dose. So very careful when people are using tamoxifen. SNRIs, venlafaxines and venlafaxines will be helpful. Dualoxetine is another SNRIs which will be 30 to 60 milligram per day will be helpful for gabapentin is another predominant. Now, those who are having a nocturnal heart flushes, gabapentin will be helpful. It will give as effective as venlafaxines. It needs to be individualized dosage. Single 100 to 300 milligram bedtime dose may suffice. Sometimes a dose of 300 milligram 3 times a day may be required for severe and frequent heart flushes. You start the low dose and increase the dose, and then once they are happy, you can either switch to other drugs if they are not happy. If you are switching from SSRI and SNRI, it is preferable to continue along with gabapentin 2 to 3 weeks SSRI and SNRI. So this is a good chart of how to give the how to treat the moderate to severe heart flushes. Mild, as I said, is no need for any drugs. Only moderate to severe, you can go for hormone replacement, or If you are predominantly, you are a nighttime hot flushes, you go for gabapentin. If they are poor response, then go for HRT. If they are before HRT, you have to assess their risk assessments. Then only if they are not able to, if they are not a candidate for HRT, then you have to go for non-hormonal. First choice is gabapentin followed by SSRI, SNRI. Now comes the newer drugs. The newer drugs which we are talking about is neurokinin B antagonists. They are fezolinetant and elinzanetant. Both are not available here. This physiology is actually physiologically active drugs which act on the kisspeptin, neuropeptin B dynephrine neurons directly adjacent to the thermoregulatory centers. So there will be studies going on. These are the two drugs highly studied. And the larger studies are conducted soon to confirm the benefit of these drugs. They are all in the trial-based, under the trial. If this trials has come out, then we don't have to depend upon hormone replacement therapy. We can go with the drugs. These are the trial is going on. In 12 weeks, it has a massive improvement. 40-week extensions, they will be having a long-term benefit. So this is again through the study. So even sleep fezolinetant has been effective in the vasomotor as well as the sleep. So thank you. Thank you.
Thank you. Thank you so very much, ma'am, for that question.
Thank you.
Thank you so very much for that wonderful talk, ma'am. It was wonderful to learn from you. Of course, first of all, the medical strategies that you talked about, the newer strategies, newer medications that have come in, because in today's day, I think hot flushes have come in a big way, and we, from the Public Awareness Committee, as this is a program of the Chennai Society, plus from the Foxy Public Awareness Committee, the program that we primarily are doing today is Preserve the Uterus program. You must have heard of it, where we are trying to prevent this unwanted hysterectomies. And that goes a long way in. We know that even if we preserve the ovaries are going to stop functioning once the target organ is out in a couple, 2 to 3 years. So that is why the way you mentioned the whole thing, the symptoms, etc. So basically, in the prevention part, also, of course, not doing an unwanted hysterectomy is something that, as you mentioned, is something that is very, very important. So, ma'am, I would like to just ask you one question, if the time allows. That is, you talked about giving medications to the patients. So do you feel that the testing that we do for the patients, like the echocardiogram, etc., lipid profile, etc., that we are supposed to do for the patients, and do you feel that taking a consent before starting these medications like Tibolone or HRT, etc., is a mandatory in today's day, especially in this medical scenarios that comes up?
Yeah, so this is this is the only area where we are thinking about estrogen therapy, because of after WHO we stopped giving estrogen therapy since 2002. So when you restart the estrogen therapy, you have to do a preliminary assessment as usual, but like lipids, liver function test, and you have to have a proper risk assessment. You have to rule out a comorbidity, especially hypertension, diabetes, metabolic syndromes, especially increased triglycerides, because before giving any HRT. So once they are eligible candidate for HRT, yes, we can give, and there is no need for routine consent to be taken before giving an hormone replacement therapy. So right now we are not practicing. And regarding the assessments like mammogram and dexamethasones, as per the annual things, if you are already done mammogram as per the annual screening, you don't have to, you just follow them. But there is no mammogram, so do look for the breast density and then any other issues, you can have a preliminary mammogram. So that is an additional test we will be doing before initiating a HRT. So consent part, I don't think so it is necessary, Dr. Priyanko.
Sure. Thank you so.
I have one question.
Thank you so much. Yeah, Sumati, yes, go on, please.
This is just one question. There's nothing else in the question answer box. So I have one thing in mind. It is not exactly a question, but it's just a discussion point regarding patients who undergo menopause. Interestingly, when we read through, we know that there are patients who undergo menopause very smoothly, and there are patients who undergo menopause with a lot of vasomotor symptoms. If all the studies point towards people who have vasomotor symptoms have more incidence of developing osteoporosis very positively. So it is our, as practitioners, it is our duty also just not to talk about vasomotor symptoms, but also proactively medicate them in a properly consented and discussed manner, so that they are not just avoiding those vasomotor symptoms. They're not just treating those vasomotor symptoms. We are treating a whole battalion of other problems which are going to come with the vasomotor symptoms. Just wanted to say that.
Yeah, they have, that is my another rest of the talk will be like, because of the time constraints of 20 minutes, we stop. They have increased risk of cardiovascular, their aortic valve thickness will be increased if you have a vasomotor disturbance. The studies have been shown, and especially heart flashes affecting the sleep and depression. So the higher risk is that they have to be properly educated. They have to modify the risk by heart flashes. People have higher risk of cardiovascular, more osteoporosis and other things.
There is also one group of patients who would have had menopause 3 to 4 years earlier. They would have suffered earlier. Right now, they're okay. But they do come back and ask, doctors, I read that I might get weak. Can I start on HRT? Right now, they must have, gotten over the hot pleasures. They are just menopausal for the past 4 or 5 years. What would they want to just proactively keep themselves healthy? No, I want to build my bone. I want to retain my bone. I want to be healthy. I want to be young. What would you advise for them?
Unless otherwise they are symptomatic, they don't have a heart flashes, though they don't have any symptoms. As a preventive parts, HRT is not an answer, Dr. Sumati. So there's only symptomatic, we can give HRT. That too, if they are eligible below 60 years.
Thank you.
Thank you.
Can we have the, thank you, Dr. Deepa.
That's sufficient. Yeah. That's good.
So thank you, Dr. Deepa, for that wonderful talk. I'm sure our viewers today have thoroughly enjoyed listening to you, because we have learned a lot from your talk. Thank you so much once again. So now, do we have Dr. Ramakrishna sir's talk first? In the meantime, I would also, of course, like to welcome Jairani ma'am. Ma'am,
Good evening, good evening, Sumati. Good evening, Kundavi. Good evening, Karpaham. Good evening, Ramakrishnan sir, and good evening, Deepa. I'm sorry, we were in the midst of a taking over ceremony in the Chennai Menopause Society. I'm taking over.
Congratulations, ma'am.
Congratulations. All the very best.
Just running around. Thank you, thank you. Thank you, Priyankur.
Congratulations, Jairani ma'am.
Thank you so much. Over to you, sir.
So next, we go on to talk another very important talk: insomnia, sleep like a Snow White. I wish our postmenopausal ladies especially could sleep like a Snow White, and if that was a possibility, definitely. And I'm sure Dr. Ramakrishna sir, after listening to his talk, will listen to the different management modalities which will help us in helping this postmenopausal woman who most of the times is not able to sleep very well. So sir is a director of the Nitra Sleep Clinic. He's a senior consultant at sleep medicine and director at the Apollo Hospitals in Chennai. He's an American board certified in internal medicine, critical care medicine, as well as sleep medicine. He is an honorary adjunct professor at the Tamil Nadu MGR University, where he's a past Vice Chancellor of the Indian College of Critical Care Medicine and past President of the Indian Sleep Disorders Association. It's indeed a matter of honor, I would say, for us to have such a senior consultant with us who will be discussing with us this important topic of insomnia. So the stage is all yours. We'll be all ears to your talk.
Thank you so much for the invitation. Let me try to get my... I don't know why I'm not seeing my desktop.
Chitrakala?
My slides?
Not yet, sir.
Sir, can you stop here and share once again, because we can see only the Zoom.
Okay, because I can...
When sharing, don't click on the PPT, sir. Click on the screen and share. Yes, sir.
Yes, sir.
Okay, perfect.
You can go to the slideshow so that.
Yeah. Okay, I think I got it.
Yeah, perfect.
Thank you so much, Dr. Sumati, for the invitation. It's a real pleasure and honor to be here. So what I'm going to do in the next about 20 minutes or so is primarily focus on the fact that sleep problems are treatable. And I'm going to talk a little bit about common sleep problems in women, outline some of the specific disorders in postmenopausal women. And most importantly, I'm going to illustrate through some case vignettes some of the problems that we see in postmenopausal women and how we could manage those. Now, the last 2 years, I think we've all been like totally engrossed with COVID and thinking about infectious diseases or communicable disease. But I think the World Health Organization in general has been focusing significantly on non-communicable disease because those are probably going to be accounting for well over 2/3 of all the deaths in the world. And when we think of non-communicable disease, the things that come to our mind often are obesity, hypertension, diabetes, heart disease, cancer. But we often forget that there is something else called sleep disorders, which is probably the most common non-communicable disease that we see, but we often forget. And more importantly, these sleep disorders can also lead to several of the other non-communicable disorders that I just mentioned. Fortunately, there has been more and more awareness being created in the media, and that seems to be helping people to directly understand that they have a problem and get it treated by the physicians. Interestingly, we did a study when we looked at 1,000 consecutive patients who presented to Nitra Sleep Clinic, and we found that most of our patients are self-referred and not referred by other doctors. And that's probably because of increasing awareness both in digital media and in print media that seems to be creating awareness on the importance of sleep. Now, as a sleep clinic, the common problems that we see are number one is insomnia, where they come to us presenting that they cannot sleep. And these are people who, after some time, will certainly seek medical attention because they absolutely cannot go without sleeping for too long. Where we have a problem is people who have excessive daytime sleepiness, where they feel sleepy throughout the day and they think they do not have a problem. Often they tell others that I don't have a problem because I can sleep anytime, anywhere, and all the time. The third group of patients we see are those with a fragmented sleep pattern, where they go to bed on time, they wake up on time, but they wake up several times in between at night. And we will talk a little bit more about this in the perimenopausal age group. There's also the group that presents with what we call parasomnias, where something abnormal happens during sleep. And that abnormality could be sleepwalking, sleep talking, sleep eating, and several of those that could bother others more than them. We also see a large number of circadian rhythm disturbances. Today, several of us are global citizens trotting all over the world. And we all know what jet lag is, but trust me, there are people who are chronically jet lagged, primarily because they are working shift works and working at times that are time zones of different countries. So in cities like Chennai, we do see a lot of people who are in the business process outsourcing or IT industry who work time zones of the US and the UK and present with multiple sleep problems relating to the circadian rhythm. Now, before I go with the specific problems with menopausal women, I wanted to just mention what the normal sleep architecture looks like. When we think about a 6 to 8 hour pattern of sleep, what I want to focus on the fact is we have 4 stages of sleep. As you can see, N1 is the stage 1, N2 is the stage 2, N3 is the stage 3, or what we call deep sleep or slow wave sleep, and R is the REM sleep. Now, approximately every 90 to 120 minutes, we go through a REM phase, as you can see marked in the green circles. The first half, you can see that the REM cycles are very short, hardly lasting for about 5 to 15 minutes. As we progress through the night, early morning hours, you see that the REM sleep is much, much longer, almost about 30 to 45 minutes. The significance of this is dreams that we have during REM sleep are what we remember, and dreams that we have during the non-REM sleep are those we do not remember. And therefore, when we wake up in the morning with a dream, we often remember that because it's from a REM sleep. Now, of all the sleep we have, about 50% of our sleep is in the stage 2 or N2. Another 20 to 25% is in stage 3. Another 20 to 25% is in REM sleep. And a very small proportion, which is only about 5%, is probably in the stage 1 or extremely light sleep. Now, the stage 3 sleep, as you can see, is very dense in the first half of the night. And REM sleep is much more dense in the second half of the night. Now, as we go through different ages, the requirement of our sleep varies. In fact, for those of you who know Tamil, when Dr. Sumati called me and said, can you speak about perimenopausal women and sleep? And she said, what will be your objective or theme? And I said, Kalamidu, Kannurangu Magale, Kalamidai Tavaravittal, Thukamillai Magale. Basically, what I meant is, when you are a child, sleep well, because as you grow up as a woman, there's a lot of sleep disturbance that you're probably likely to have. This is a very old Tamil song from the 50s or 60s, I don't recall. But as you can see, when you are a newborn, you sleep almost for about 14 to 17 hours, and that gradually shrinks over a period of time. And as adults, most of us require somewhere around 6 to 8 hours of sleep. 6 to 8 hours is what is acceptable, but there are some who have less and some who have more. But how do you determine that the sleep you get is good enough? If you wake up feeling awake, alert, active, and energetic the following day, that sleep is probably enough for us. Now, this has been evolving over the years because sleep is truly a lifestyle-related problem. Earlier years, when we didn't have cell phones, when we didn't have long commutes, and when we came home and relaxed and were able to sleep, most of us probably slept much longer, but that has been shrinking. And now in the 2000s, most of us are happy if we get somewhere around 6 to 6.5 hours. But remember that women need approximately 20 minutes more sleep than men, and definitely not less, but most of them probably don't get it. Now, why are they not getting good sleep? Now, you can see from this study, which is a survey done long back, where 60% of the women said they get a good night's sleep only a few nights per week or less. That's, you're talking about 39%. So almost 2/3 of them probably are not getting a full good night's sleep. And what could this be due to? One, certainly lifestyle. Working mothers, single working women are more likely to experience sleep problems like insomnia. Certainly other factors like noise and what we call spousal arousal syndrome, whereby the husband might be snoring and that could be disturbing the wife's sleep. Care to children, care to pets. Several of these seem to be playing a significant role in women getting less sleep. And certainly the unique physiology relating to hormonal changes that all of you know better than me certainly can disrupt sleep. And in general, women are more likely than men to report poor sleep and are also more likely to experience daytime sleepiness and 3 times more likely to suffer insomnia and also experience more depression, anxiety that could possibly disrupt sleep. Idea is not to get into the deep science of all of these, but I do want to specifically mention that the estrogen and progesterone hormones do affect various neurotransmitters and chemicals in the brain, particularly adenosine and prostaglandins that could reduce the sleep drive and reduce the REM and non-REM sleep, and also have impact on the hypocretin hormone or the orexin hormone, the histamine transmission, and the norepinephrine, all of which could increase wakefulness and make them remain aroused. Okay. Now, I know we are focusing on menopause, but I do want to mention that right from menarche all the way to menopause, there are certain changes that happen, particularly during pregnancy, where there could be significant sleep disturbances. And in menopause, as you can see, insomnia is extremely common, and women experience more what we call wakefulness after sleep onset, or VASO, because they could go to sleep, but they may have multiple arousals. They're also often limited because of the other commitments that they have. Okay. So we just heard about hot flashes, and those could certainly be disrupting sleep. But I do want to reinforce the fact that HRT seems to be kind of inconclusive as far as treatment for insomnia in perimenopausal women or menopausal women. Now, what happens if somebody doesn't get enough sleep? Just imagine one night when you didn't get a good night's sleep, and think about the following day. You wake up with your eyes feeling red, waking up with headache, often feeling irritable, unable to focus, probably feeling very sleepy during the daytime. All this, if you can multiply over several days, that's really what happens when people have a sleep debt or have inadequate sleep for many many days at a time. So they could be feeling sleepy, they could experience high stress, spend much less time socially, too tired for sex, feeling drowsy, feeling tired during the daytime. Okay, all of those could certainly be happening in anyone, whether it's women or men with insomnia. I'll move on to 3 case vignettes and quickly close to be on time. The first one is somebody who is sleepless, a 50-year-old woman, difficulty falling asleep and subsequent frequent awakenings over the past 6 months, having hot flashes, cold chills, restlessness, palpitation, disturbing sleep, frequent arguments with the husband over temperature setting in the bedroom. I'm sure several of us have played the remote control game where the husband and the wife require different room temperature that's comfortable for them to help them sleep. She wakes up feeling non-refreshed, denies any snoring, restless legs, or comorbidities. So what is the diagnosis? Here is somebody who has difficulty both falling asleep and maintaining the sleep. So we call this as sleep onset and sleep maintenance insomnia. And it's extremely common in perimenopausal women. As you can see, depending on the studies that you look at, it's almost 38 to 60% significant variation that you can see. HRP reports are variable, and they may require cognitive behavioral therapy along with medications, and usually benzodiazepines and what we call the Z drugs, which are benzodiazepine receptor agonists, like zolpidem, any of those could be used. But it is recommended that in women, the dose of zolpidem should probably be lesser than what you use in men. Usually 5 milligram dose is good enough for most of them. But we need to pick the right drug based on the duration of action, prior response, and if there has been any significance tolerance. Okay. Now, how long do we really treat? That's pretty variable. So you have to follow them closely. If somebody has trouble sleeping for 2 weeks or more without any obvious provoking factor, then it is insomnia. And if it's less than 3 months, we call it a short-term insomnia. And if it is longer than that, we call it as chronic insomnia, which really needs to be managed. The non-pharmacological management does include what we call sleep hygiene measures, teaching them appropriate measure, which I will mention again in the end, cognitive behavioral therapy, stimulus control, relaxation techniques, and of course, if it is related to hot flushes or the room temperature, using appropriate thermoregulated blankets, mattresses, and there are now new smart mattresses that are coming, which actually claim that the husband and wife can experience different temperature that's appropriate for them and probably be able to sleep better. Now, do all these patients who present to us with insomnia really need sleep study? Probably not, absolutely not. So we don't do sleep studies on everyone. We need to find out if there is obvious reasons for them to have the insomnia and need to support them with CBT and also medications briefly if required. We'll move on to Good Night. And for those of you in Tamil Nadu, if any of you saw this new movie called Good Night about snoring, well, Good Night, not really. And that's what we'll talk about. This is a 52-year-old woman with complaints of non-refreshing sleep. His story, which is the husband's story, was that she was snoring loudly, and he noticed that she had some choking episodes, and the symptoms have worsened since menopause and the fact that she gained weight recently. Now, what was her story? She was saying that she wakes up several times at night because she feels like urinating, has significant dryness of the mouth, wakes up not feeling fresh, has significant headaches, and feels tired and sleepy all through the day. And she also said that she's really struggling with symptoms of acid reflux, uncontrolled diabetes, and the hemoglobin A1C was going up to the 8s and 9s, and also the hypertension that was poorly controlled. Now, there is also their story, which is the family story, because they observed that she is increasingly forgetful, irritable, and certainly not her usual self. Now, here is somebody who clearly has what we call sleep disordered breathing or obstructive sleep apnea. And the common symptoms are during the night, they have loud, persistent snoring, invariably noticed by the bed partner, often noticed to also have witness pauses where they stop breathing, or they could be choking or gasping for air. And overall, they are restless, but wake up frequently to go to the bathroom, because obstructive sleep apnea can stimulate atrial natriuretic peptide, which really makes them have nocturia. Now, during these episodes, when their breathing is not normal, their oxygen level comes down, and therefore they often wake up feeling not fresh, have headaches in the morning, feel sleepy during the daytime, cannot concentrate at work, feel more irritable, and they fall asleep while at work and even while driving, which could be costing their life at times. Now, if somebody has these symptoms of sleepiness, what do? The first thing is we do a subjective questionnaire, which is called Epworth Sleepiness Study, where we look at what is their chance of sleeping when they are doing any of these activities, whether they are sitting and reading, watching TV, they are inactive, or even when they are talking to someone. And a score of more than 10 in this would probably tell you that there is significant sleepiness. But there's also the objective measures that we can do, where we can do a sleep study, which will give us much more information on their quality of sleep, how they are sleeping, whether they are snoring, whether they have obstructive sleep apnea. And there are different types of sleep studies. I do not want to get into the details, but this is an in-lab polysomnogram, which is considered the gold standard, where you have the EEG to look at the stages of sleep, you look at their breathing pattern, you look at their oxygen level, you can see if they are moving their legs, and all of those will give you an idea on what is happening. Now, more importantly, there is also what we call a portable sleep study, which can be done at home, but that's limited to looking for sleep apnea. It is only a cardiorespiratory study. And what we do there is we look at how they are breathing and whether their breathing is slowing or stopping. So stopping breathing is called apnea, slowing breathing is called hypopnea. We count all the events and average per hour, which is called apnea-hypopnea index. And the apnea-hypopnea index, if it is less than 5, is considered normal or just primary snoring. If it is 5 to 15, it is called mild sleep apnea. If it is 15 to 30, it's moderate. And if it's more than 30, it is severe. A portable sleep study done at home, if it turns positive, is very helpful. But if it is negative, may not rule out sleep apnea, because if the patient didn't sleep well on the night that the study was done, then it may give you inaccurate results. I do want to reinforce the fact that obstructive sleep apnea not only causes daytime sleepiness, but has been clearly shown to be an independent risk factor for hypertension, for diabetes, for heart disease, and for stroke. And for those who already have hypertension or already have diabetes, clearly it can lead to poor control of hypertension and diabetes. So if somebody has a difficulty controlling their HbA1c or requires more than 2 medications for their hypertension, and if they are snoring, it would be prudent to rule out sleep apnea. So if somebody is suspected to have sleep apnea, we do a sleep study. And if the apnea-hypopnea index is less than 15, which is basically mild sleep apnea, there are some alternatives that we can use called oral appliances, giving them some sleep hygiene measures like sleeping on the side, losing weight, all of those would help. But if they have moderate or severe sleep apnea, then usually we recommend CPAP, which is continuous positive airway pressure, or surgery in some patients, particularly if they have a significant obstruction noted on ENT examination. Now, in general, sleep apnea is higher or more prevalent in men, but in premenopausal women, there's some protection from the body structure and also, the higher progesterone level or estrogen level. But right around menopause or perimenopausal, clearly there is an overlap when the OSA prevalence is very similar to what men could have. So perimenopausal women, think about obstructive sleep apnea if any of these symptoms are noted. The last patient, 50-year-old woman, presented to psychiatrist with history of mood disturbance, low self-esteem, crying spells for 6 months, family reported that the symptoms have been worse since menopause and that the couple do not have any children and had extensive infertility workup in the past. These are all real life cases, by the way. The lab test suggestive of hypothyroidism and anemia requiring further workup. A diagnosis of depression was made, and we do see this particularly in infertile couples right around menopause, because when they lose hope at that time, and the incidence of depression is certainly higher. And the patient was started on escitalopram 10 milligram, but a week later presented with abnormal sensation over the lower extremities, relieved only with movement and massage. And the sleep pattern was much worsened, and that further aggravated the anxiety and depression. Now, this patient has restless leg syndrome, probably related to her underlying hypothyroidism, anemia, all of those, but precipitated by the fact that she was started on an SSRI, and that probably made things worse. In restless leg syndrome, they have a desire to move the limbs, usually associated with some kind of tingling, numbness, extremely restless, and they feel much worse when they are lying down and at rest, and partially it is relieved by activity, usually worse in the evenings or at night. Very common during pregnancy, but the other common diseases that are associated with that are diabetes, chronic kidney disease, iron deficiency, even if the person is not anemic, and B12 deficiency, and any kind of chronic pain syndromes, whether it is back pain, leg pain, joint pain, any of those. And the way we treat this is, number one, certainly cutting down on caffeine, nicotine, alcohol, any of those. Hot baths and stretching exercises before bedtime certainly seem to help them significantly. And there are medications that we can use if the patient is iron deficiency, is iron deficient. You can replace. You can use some benzodiazepines, dopaminergic agents, anticonvulsants, particularly gabapentin, pregabalin, have all been used. And sometimes, if it is related to chronic pain syndromes, we may need to even use narcotic analgesics. So I would like to close by talking about what I think are 7 habits for having a highly effective sleep. Number one, keep a schedule. You need to sleep on time. You need to wake up on time, just similar to how you want to have eating on time and exercise on time. You need to sleep on time as well. Of course, 1 or 2 days, sometimes you may be able to avoid that, but as long as overall you have a regular sleeping pattern, it certainly makes a difference. Limit non-sleeping bedtime. By that, I mean there are so many people who are in bed trying to watch TV, reading a book, or using their phone, watching social media, any of those, and that's certainly discouraged. If you want to do any of those, do outside the bed, and when the bed is meant only for sleep and intimacy with your partner and for nothing else. Unplug 30 minutes before, do some kind of relaxation before you can sleep. Optimize your sleep environment. By that, I mean both the bed, pillows, room environment, room temperature, all of those. Avoid or limit alcohol and caffeine, particularly about 4 to 5 hours before bedtime. Recognize inadequate sleep early and seek help, particularly if you're having insomnia unprovoked for 2 weeks or longer. It certainly needs to be evaluated and treated. But remember, because there are people who get extremely anxious even when they don't sleep well for one night, and the bed anxiety itself can worsen insomnia. So keep all those in mind. And as obstetricians, as any general practitioner, I would like to say that, please ask 3 questions relating to sleep. How is your sleep at night? How is the quantity? How is the quality? Are you sleepy during the daytime? Does anything unusual happen during your sleep? By that, I mean snoring, restless leg, parasomnias, any of those. And this would pick up most sleep problems, and you can refer appropriately. I'm wishing you all a good night, because a good night is certainly essential for a good day. Thank you, and I'm happy to take some questions.
Sir, first question is from me.
Yeah.
Sir, what is the best drug? See, we go through a proper diet, proper exercise, but still, there are people who don't get sleep at all. So what is the best drug that you advise, especially in the menopausal age group? Because already they will be depressed. If you take a sedative, then they will be in morning, they'll be a little dizzy, they'll have a headache. If the usual medicines, what you give for sleep, sometimes it is not very acceptable many times for many of the people who are working. So what is the best? Their senses to be suppressed, their thinking should not be depressed, everything with that safety, which is the best drug you will advise for a menopausal sleeplessness?
Okay, I mean, honestly, it is like asking which is the best car, okay? Because to some people, it could be Mercedes-Benz, to somebody else, it could be a Maruti, because all of them have 4 wheels and all of them take you from point A to point B, and it's your own personal preference. So why I'm bringing that to start with is because I think you need to tailor what would be appropriate for them. If you feel that you need something that's short acting and not having a significant daytime drowsiness, usually something short acting like what we call the Z drugs, like zolpidem or zopicon or S-zopiclone. These are all available that are reasonably good to start with. The only thing we always tell people is, remember that when you start taking medications, you need to be under supervision and follow up and taper and stop, because most of them either abruptly try to stop it themselves, or they say, like 1 didn't work, I started taking 2, because chronic medications is definitely going to lead both to tolerance and dependence unless it is supervised and appropriately tapered.
So what is your experience? If they start taking it, it automatically, they need that. Otherwise, they don't feel
That's not true. That's not true. Is that true for hypertension drugs and diabetes? No. I mean, like, as it's insomnia is a medical problem very similar to, hypertension, diabetes, heart disease, any of those. I tell people, don't be resistant to starting medications, because if you need it, you need it. Everything in life is balancing risk versus benefit. Not sleeping is going to lead to more problems than sleeping with medications. But do not, just like how you would not adjust your cardiac medications or a blood pressure medication, you don't take a call and reduce those medications or stop it. You come under supervision, several of them come off it when it's not required.
Sir, I have one question.
Advice about melatonin, sir. They say nowadays the melatonin has a very good effect. What is your thought, or you may be the right person to say a few things about melatonin and its use in the menopausal?
Sure. So melatonin was originally more useful for circadian rhythm disturbances, because what happens is during the daytime when we expose our body to sunlight, our vitamin D level goes up, but the melatonin level comes down. During the night, when we expose our body to darkness, the melatonin level goes up, and that helps to sleep. So it's considered a natural, if I may say so, natural way to sleep. And unfortunately, even countries like US, this is does not require a prescription. It's a non-prescription drug. And therefore, people started using it widely, as a sleep aid. But it is more helpful in people who, if you think that they're not getting enough sunlight exposure, and that's the reason, sure, I would go ahead and use melatonin. Melatonin can be tried for a short-term period in people who are not getting, good deep sleep, because there's no way to estimate a melatonin level. Vitamin D may indirectly give you a clue, but I think I'm not a big believer in vitamin D levels here, because I think we probably need a completely different scale on normal range, because everybody looks deficient despite the sunlight that we have. So, we can use melatonin. It's definitely helpful in circadian rhythm disturbances. It has also been shown to help in some REM behavioral disorders and others. But for insomnia, I would reserve it for chronic use, not routinely. Short period, yes. Dr. Sumati, you had some question?
Yes, sir. Regarding the circadian rhythm disturbances, we do have in our practice looking at perimenopausal and postmenopausal women in particular who have been active and who never had any problem, but do have these circadian rhythm disturbances. They are active women who are working also sometimes elsewhere. And these people come up with some questions, meaning, I used to sleep from 11 to 6 and I used to be ambulant and all that. Now I'm unable to sleep by 2, but I'm able to sleep from 2 to 9. But I'm able to do the same exercise, what I'm unable to do in the morning, I'm doing in the evening. Is the rhythm alone, will the rhythm alone, if the lady is able to sleep from 2 to 9, is the rhythm alone going to affect her? Or is there anything in, I hope you got my question.
Yeah, I got your question. So let me just say, see, there is something called socially acceptable hours of sleeping and normal sleep hours. So most of us would sleep sometime between 9 to 11 p.m. and wake up sometime between 5 to 7 a.m. That's the normal pattern. Within this period, you could sleep 6 hours, 7 hours, 8 hours, whatever your body needs to wake up awake, alert, and fresh. Now, in adolescent children, a lot of them will have what we call delayed sleep phase syndrome. Classic, adolescent 11th graders, 12th graders, college students, they will start sleeping only at 1 a.m. or 2 a.m., but can sleep till about 9 o'clock, 10 o'clock. But unfortunately, they can't because they have to get up and go to college or school. And therefore, their sleep gets deprived. In older adults, particularly post-retirement, post-menopausal, the usual thing is advanced sleep phase, where they sleep very early. They sleep around 6 or 7 o'clock and wake up around 2 a.m. and then they don't know what to do. So that's much more common. Now, we tell people that if you are getting adequate sleep and that is okay with your lifestyle, there are some retired people who say, I'm okay with sleeping early, I do this, that, whatever. Then I don't try to manipulate that too much. But if it is affecting your daytime, like for example, the school student who has to go to school at 7, but sleeps only at 2 or 3 and getting light, then we may have to, we do some light therapy. We use melatonin sometimes if it's required, phototherapy and melatonin seems to help. So, yes, there are people who have only circadian disturbance, but not the duration that's disturbed. You're absolutely right.
Okay, sir. A mark of a cream speaker is not just having knowledge and experience. The creativity in your presentation really held our attention. The charm and ability to retain the complete audience attention and to clear all the doubts is not everybody's ball of game. Thank you so much for that.
Thank you so much.
Thank you, thank you so much, sir. It was very, very enlightening. I just have one small question. There are a lot of people who actually sleep quite a long time during the afternoon session after this lunch siesta. And they complain of sleep disturbance in the night, that they can't sleep till 12 o'clock, 1 o'clock. So what is the effect of this afternoon sleep on the night sleep?
Sure. So I told you the highest propensity to sleep is in the night. The second highest propensity to sleep is in the afternoon, right after lunch. Classic, unda kalaipu thondanukkum undu. So, like everybody can sleep during right after lunchtime. Now, some of the cultures, like the Spanish cultures, have used the siesta because those are called power naps. You feel a lot more fresh, but it has to be a nap. It has to be 20 to 30 minutes and not 2 hours. That's not a nap, that's sleep. So I tell people that if your work schedule allows you to have a short nap, and if it's helping you and if it's not disturbing your night sleep, you're okay with it. But if you have a nighttime sleep disturbance, avoid a nap, because your total sleep time for the day counts both your afternoon and night, and therefore you should be. Okay.
So last question, very much, it may not be routine. Which is the best food you advise to take before you go to bed that will help you for a sleep?
Okay.
They say, somebody say milk, somebody say buttermilk, somebody say curd. What is your
anything that contains tryptophan, serotonin? So usually we recommend milk with honey if they don't have diabetes or anything like that, banana, and chamomile tea. These are the ones that seem to help a lot of people.
I wrote it down.
And with your permission, if that's the question, I'll take your permission and leave.
Thank you so much, sir.
Thank you so much, sir. Thank you very much. Thank you.
Pleasure.
Thank you so much, sir, Dr. Ramakrishnan, for that wonderful talk. It was really enlightening listening to you.
Thank you.
So thank you so much, sir. So now I think after such a extensive question answer session, which Dr. Ramakrishna gave all the answers to all of them with a smile, we move on to the next speaker, who's again always smiling, and she asked the questions with a smile as well. And now I'm sure she, with the ball on her court, she'll be answering the questions that will be put forward to her with a smile as well. So I introduce the next speaker, Dr. Jairani Kamraj ma'am, who's going to talk to us on perimenopausal sex woes, tackling tips for gynacs. Ma'am is a senior consultant of reproductive medicine, director at the Akash Fertility Center, is currently the president of the OBGYN Society of Chennai, She's the treasurer of TAPISAR, and we have heard that she has currently taken over as the executive committee member of the Chennai Menopause Society as well. Congratulations for that, ma'am.
Thank
She
you.
received a number of awards, including an award from the MGR University, received a gold medal from there, and she's a member of various societies. She's also a world member of Associate Secretary of the World Association for Sexual Health Advisory Council, as well as the World Association for Sexual Health. I hand over the stage to ma'am, and before that, I would like to wish her all the best for her future endeavors in Foxy, because she's been working a lot towards sexual health across the country, and I'm sure it's going to benefit women at large. Over to you, ma'am.
Thank you, Priyanka. Thank you for your nice words, and thank you for your wishes, and thank you for making this wonderful webinar on the Public Awareness Committee along with my OXY team. The Midlife Committee and the Public Awareness Committee. It has been a great, tremendous work you people are doing. And I really appreciate the lot of activities you are creating, a lot of awareness among the gynae as well as the public. And I really thank you for making our team work with you to get into this heights, and really looking forward a lot of all my team members working a lot for this with you. Thank you so much, Priyanka.
Tamil Nadu is always a home. So whenever I get a chance, it's virtual or physical, I'm always there. So thank you so much for the opportunity.
Thank you, Priyanka. Thank you, Sumati. And let me share my screen. Chitrakala, can you help me?
Yes, ma'am.
Yeah.
Yes, ma'am. We can see the screen, ma'am.
Yeah. Is it okay? Can you hear me? And can you see? Yes. Yeah. Right. So, so now we have come after the sleep. We have come a part that is before sleep. Ideally, this should have come as the second one, but I think we are just coming after the sleep. So it's good that it starts the sleep. That's what all knows, that one of the best sleep medicine is the sex. Sex gives you a lot of energy. It spends a lot of energy and makes you good sleep to come. And then there comes a problem in the menopause. The woman goes through a lot of problem related to her sex. So let's see how this mysterious frame of menopause looks into the life of the women regarding the sexual life. So as a woman and a gynecologist, I have come to embrace this stage in life. I'd like to explain menopause not as a disease, but rather as a transformation time in a woman's life, one that can be quite amazing. So it is just like saying age is not issue of mind over matter. If you don't mind, it doesn't matter. That's how you have to look into the menopause. So it is really a mysterious time frame which goes through a woman entering a menopause, which is an absence of menses for 10 to 12 months. And she has a lot of time before that, a perimenopausal period in the menopause, where she is going through a lot of changes in her life because of the various changes that she goes through. So this is the complexity of the changes that happens in a woman, the beauty of the woman and her journey through the life, which is really variable and which is really, it cannot be put into a time, into a frame that she will have all these things to come through and then she will land up in this problem. Some people may not have anything, they may land up in some problem. So it is totally unpredictable and the journey is really variable in the women's life. So we as a gynec has to look into every aspect of this menopause in a different way, because many times the women may remain totally asymptomatic in the menopause, and sometimes they may go through a lot of symptoms in the menopause. And definitely you cannot exactly put forth which women will have a night sweats, which will have a hot flashes, which may have more vaginal dryness, which will come first, which will come last. Everything has a lot of variability, but generally a woman goes through many important events because of lot of changes in the hormones, as we all know. So the most overlooked symptoms, because you know pretty well Deepa has given a very nice talk about the hot flushes and also about the sleeplessness by Dr. Sleep Specialist. So we all know those are all very part and parcel of the menopause, because many times they come with this problem very clear to the doctor, to the gynae. Doctor, I don't have a sleep, I have a hot flushes, I have a palpitations, I have a mood changes, I have a lot of emotional disturbance, which is quite natural that they come through. But the one thing which they are really have a very overlooked, which they don't come out with that problem, is the decreased sexual life and there's intimacy. But that is the one which has a great brunt in her menopausal life, which she looks forward as a very great stress in her life. Because a woman being an active in sex before the menopause or in the perimenopausal period, she'll be really landing into a lot of doubts and dilemmas, and also have a lot of questions to her, but she don't know how to ask, whether it is right to ask, whether to how to ask. Everything becomes a question for her. So the hormone levels, as it is, they create a lot of stress in her. And also the stress of the menopause makes her more for all this problem. And the doubts and dilemmas she has about all the changes, which makes her very much difficult. So all this ultimately leading into a decreased sexual intimacy, decreased sex, and also a problem of sex. And many women don't get the help they need to keep this sexual intimacy and the intercourse as a priority, but they should be, because many a times, many of the problems which happens in a menopause, the basic underlying problem is the problem related to the sex. But because if you talk with any menopausal women coming with some varied symptoms, if you ask her about the question, just open a talk about her about the sex life, then she will come out with a lot of outpouring in her way. She will say, doctor, the menopause is coming. Nowadays, especially when the women are more into the open talk, they have a lot of open blog and open forum. They have a lot of things to talk about. They will be just asking whether I'll be happy with my husband, with my sex life after menopause, because many times there are a lot of medications for your night flush, your hot flushes, night sweats, everything is there. But will I have an effect? Will I have a solution for the menopausal symptoms of whether I can satisfy my husband, how I'm going to look into the emotional changes? And definitely my interest in the sex drive is low. Will it be okay? How long will it be low? Will it be very low? Will I be able to satisfy my husband? All these things will happen a lot. And all the more, whether I have an orgasm, whether my intimacy with the husband and the relationship will be going down, and how will be my desire? All these things are a lot of questions. If you ask one leading question to the women, she will come through with a lot of doubts. And very well, pretty well, we know definitely all the changes of the hormones definitely have a decline in the interest in the sex. This is also very important, not because of her hormones, but also because of its effects in the sleeping patterns, a lot of changes in the metabolism, which leads to a lot of aches and pains and headaches and fatigues and flushes, which makes her go for a lot of problem regarding her self-esteem and her image. All this gets into a lot of trouble. And because of this, she goes a lot of problem in the sex. And all the more the menopausal symptoms, we know pretty well, the physical menopausal symptoms, because of the hormones, they go for all the atrophy of the genitourinary system, which causes a lot of effect on her sexual life, causing a vaginal tightness, dryness, and irritation. And all the more because of this, she goes for a urinary leakage and incontinence, and thereby that creates a lot of physical problem, which may lead to a decreased desire, she has a lot of apprehension of doing a sex, and that causes a lot of insensitivity in the genitourinary system, as well as in the genitals, especially in the clitoral, where there is a decrease in the sensitivity. And because of all these changes, she has a lot of pain, which may lead to pain during sex. So how we are going to tackle the symptoms and the distress of these women? How? With what? With whom? That gives a lot of thinking in the gynec practice. We have to look into all these things for these women. So first and foremost, when you come across a woman with this complaint, the first thing you have to tell her, see, you're going through a phase of a life. Get yourself as a champion for this new yourself. You make it as a new life. You make it as look at it in a different way. That will make you more emotionally stable and look this part of your life in a different way. That is a very important aspect that you should insist to this women, because many times they come with a lot of self-esteem getting lowered, but you should tell her, this is a time that you have to be happy about it, because you don't have a menses, you don't have worry of a pregnancy, you can have a lot of times of sex without a fear of pregnancy. All those things will help her to look this in a different way. That part of a counseling, very important, that you have to make this part of her life. You have to tell her, don't account or anticipate this and plan for the changes that come with the menopause. See, there are a lot of physical changes which will come, but you have to plan for these changes. If you plan it properly with a good anticipation, you can look through this problem in the best way. So there comes the journey that begins in the menopause. Doesn't have to be miserable or lonely. And often the society interprets menopause as a negative, coloring women's experience and journey with biases even before it begins. So you have to counsel her that how she's going to plan the menopause. There comes our perimenopausal period. Every gynecologist should take an opportunity to talk with your patient in the perimenopause, prepare her for the menopause. That is a very important aspect. Because many times you will tell her irregular periods you may get a menopause, but you don't look into this aspect of her life, which is a very important one that you should talk to her so that she will take over this journey in the best way. So the part of this journey, which includes a very important way, you have to narrate her how this is going to happen. What is the thing that she can do? How she can get the professional help? And it's not the professional gynae alone. She can get the sleep problem consultants. She can get the urologist help. She can have a psychological stress. All these things has to be given to her in a proper way so that she will take it up in the best way with the best understanding, so that the menopause isn't just a physical changes. She has to look into all the psychological aspect also, which makes her well prepared for this problem, which she goes through in this part of her life. So all these things has to be counseled to her in the correct way so that she looks upon in this way in a better way. So first comes when a woman comes to you with a vaginal dryness, what are you going to tell her? First, just tell her this is one of the natural changes, just like your skin gets dry, your skin gets wrinkled, your private parts also gets dry. So you just apply a lubricant. As you apply a moisturizer, you apply a lubricant. This will help you to make the genital dryness goes off, and you will increase the sexual pleasure, and that will decrease her discomfort and soreness. You have to tell her how to choose the lubric jelly or your creams, how the lubricant. You have to prescribe her in the best way so that it will not irritate her. It will not make her skin sensitive. That will help her to make it much more favorable. And all the more, you can give her even a scented lubric, which will help her to reduce the irritation, makes it more pleasurable. And usually see to that it has less allergic effects. That should be very important. And also, you can prescribe her along with that an estrogen cream, which will help her to get over this dryness, as well as improve the genital epithelialization, which will help her to prevent this atrophy. And next comes in emotional changes. Yes, you have to involve yourself in the emotional and the mental health of the women and tell her there will be a lot of changes in you, like your irritability, mood changes, stresses, especially in the workplace, as well as worry, stress, everything will be there. But how you're going to make all this symptom to her in a good way. So you tell her this is a journey of recreating balance and discovering new beginnings in the relationship within yourself. So that is a very important part of her life that she should understand to go through. So as a healthcare providers, especially we gynecologists, we are trained to think these symptoms, how they affect the women individually, and what are the best therapies we can give them to minimize the effects. And also it should start with implementing better understanding of good health practices, promoting healthy lifestyles. So the integrity of our sexual health and well-being should certainly be no exception, especially in the menopausal women. So you have to address every symptoms of her. The first is the very important one is the low libido, which is a very commonly expressed symptoms among the women. This is always needs a new knowledge, which can minimize the negative impacts on the quality of the life of the women and gives her a better emotional satisfaction and better emotional intimacy. That requires a possibility to continue having a healthy sexual relationship. So how you can satisfy your husband if she comes and asks you, you tell her very simple way, add some wetness. You can use a lubric cream, you can use a moisturizing cream, you can use some moisturizer or something which can lubricate your lubricating in a better way. That will help you to have a better pleasurable one. Use a moisturizer, and even you can prescribe her medicine. You tell her, if you come and ask me, I'll give you some medicine for that. And then of course, if you feel very much your pelvic is very lax, sometimes they may have an associated prolapse, they may have a associated cystocele or rectocele, give them a pelvic floor therapy. That will give them a better tone of their pelvic floor to have a better sexual effect. And also give them the mind stress. You give them a yoga, meditation. Many times, sometimes they may be very lonely. They may have a lonely way. They don't have a partner sometime in a menopausal time. They can use a vibration therapy or even a lonely masturbation. That may help to play them with a sex toys. That will help them more for that. And very times, you can give them very much spending more time on some erogenous play, not the penetrative sex alone. They can have a lot of intimacy acts to improve their arousal. That may feel very much connected to your partner. And also give them a sensual massage that is there, and even a candlelight bath together. That may give them all the senses. And very interestingly, they have found out talking about the past sexual experiences, what they had in the past, to talk about it, to kindle their older thoughts. Maybe that will give them a more pleasurable among the partners. That it has to be practiced, and that has to be talked to the couple, which will help them to have a better way. Another way is the women feeling, Doctor, will my orgasm be difficult this time when I get into the menopause? I used to have a good orgasm. Will it get the menopausal changes? Will it reduce my orgasm? Yes, it may reduce your orgasm, but don't feel frightened about it. There are very many methods to improve it. If you feel that the orgasm is low, get the vaginal dryness. That's the cause. You treat the vaginal dryness. That may improve your orgasm. That will help you more. And all the more your hormones, which are very much reduced, which can be treated with some locally acting estrogen, which may help to improve her lubrication. That will help her in a better orgasm. And even when you have to have a orgasm, they can try some direct stimulation, which will be very helpful for the menopausal transition period, which will improve the blood flow to the vagina and the clitoris. Thereby, there can be an improvement in the orgasm, because many times in the menopause, there is a reduction in the blood flow in the vagina and the clitoris, but the direct stimulation will help to improve the blood flow, which will help to increase the pleasure. So these are all the things that you can tell her. We can tell her about the touching. We even teach them how to touch, how to stroke, how to rub, and how to improve the moisturizing effect as well as the blood flow. That will help them to have a better clitoral stimulation. And even you can ask them to do an oral sex, which will helpful for better stimulation and better lubrication. And that will be a better help for the lubrication. And even we can advise them a vibrators or a sex toys, which will be helpful for them either as a partner or solo sex, which will boost their sensitivity and wetness, make it easy to reach the orgasm. So when they have a low libido, you have to tell them that you have to rediscover what your libido means to you. It is variable. Everybody has a different type of a libido. One may have a complex, it's a very complex act of the sexuality. So many people are even uncomfortable of discussing that. Many times, many have a lot of, they may have a lot of fantasy, they may have a lot of visual things. So each thing will be varying. So it is not that everybody will have a standard way of a libido. So you can't measure the libido. If she says, I have a low libido, you can't measure this. There's no way that you can measure it. But there is a way that you have to tell. It is a partnered way. So you have to tell that how you feel well about the arousal. What are the moments that makes you more excited? How you can improve your intimacy by lot of, with the lifestyle, with your technology and the medications, all will help to improve the lubrication as well as to improve the libido. So tips, if you want to tell the patient is, you change your sexual routines. You have a different way of sex. Either they can have a sex in the, they can have in the dining room, they may have in the hall. There is a different way, not the penetrative sex alone. There can be any number of type of foreplay, which may help in that way. So you focus more on foreplay. That will improve your libido as well as improve the incorporating vibrators and toys, sex toys. That will be also be helpful. So more importantly, a well-rounded approach to treat the libido, decreasing libido, should integrate the medical, psychosexual, as well as pelvic exercise and a lot of counseling, and that will have a holistic approach, which will give them a better libido. So what are the therapies which we give generally? Because many a times they may have a lot of other ailments too. Sometimes they may be taking a lot of medications. So many a times there are not of much medications we can give them orally, but there are a lot of mind-body activities which can help them relieve the symptoms that interfere with their sexual intimacy and desire, and even their sleep quality. These include the mindfulness therapy, the Tai Chi technique, acupuncture, yoga, stress relief techniques. These all should be explored extensively as well. These can also improve their intimacy, and their sexual stimulation will be improved, and feeling more comfortable with the sexual activity, especially after menopause. See, these are all the therapies that usually advise. And when you come to medications, definitely there is no shame in rebalancing yourself with medications. Definitely for some people, the desire may be still strong, but other physical symptoms can get in the way. They may be much desirable, but the physical symptoms may not be giving them enough to participate in the active sex. So sometimes they may have a more vaginal atrophy, more the vaginal shrinkage, may have a pain during sex, but still they will have a lot of desire to be with a partner, to do a penetrative sex. So for them, you have to get in the medical advice of giving them a proper estrogen. It could be an oral estrogen, or it could be a locally acting transdermal patch, which will give them a better relief of the vaginal atrophy. That will give them a better comfort. And also, when you have to examine them, if there is a prolapse, which could be the cause for the painful sex, you have to advise them about the HRT, which are very importantly used when they have a real symptom of atrophy and the prolapse, which may improve their sexual their sexual act, as well as they can plan their penetrative sex without much of a pain. And this will also help for the vasomotor symptoms. And very importantly, one drug which is approved by the FDA is the flibanserin, but in aged women, especially in the menopause, flibanserin, I have not mentioned the flibanserin here because flibanserin should be given very careful in an elderly women, because we are now talking about the perimenopausal women. In a young women with a hypoactive desire disorder, that is the only approved drug. But in the therapy, the only drug which can be used is the testosterone. But though the FDA hasn't approved it, but still the best and safest therapy for a perimenopausal women with a low libido, low desire to improve their sexual intimacy, the only drug which can be used is the testosterone, which can be given as a patches and creams or even oral tablets. There are good transdermal testosterone products which are available all over the country, which can be used safely. And very importantly, they have given a lot of herbal supplements which may help to improve the libido, especially for the women. The soy, we know, because the estrogen is there, and the black cautious that has a lot of estrogen, and the red clover. All these things can be added in the food, which may improve the natural estrogen, the phytoestrogens, which may help to improve the vaginal changes. So I'm not going into much of the drugs which are used for the hypoactive desire disorder, because many times in the elderly women, many drugs are contraindicated. So we have to try more of a natural therapy, more of a natural improvement, and not medications, only locally acting medications, especially for very severe atrophy. You can give an HRT in the form of a locally acting pessaries or a cream or a patches. And of course, testosterone is the one for the libido. These are the two drugs of choice. And of course, more of lubricants, which could be either a lubric gel or it could be a moisturizer type, which may improve the skin changes and the atrophic changes. So these are all the things that you should always do with care. So as a gynec care people who are looking into the genital organs, which are the prime organs of sex, we should educate ourselves. So whenever a woman comes with a menopause, the very important question we should put for them is the sex, how it is being affected in her personal life. And definitely we have to look into the personal life of this woman and give her the proper supportive care in the form of counseling, in the form of difficulties, what she's looking into it, and thereby which can improve their quality of life. So it all starts with implementing the better understanding of good health practices and promoting healthy lifestyles. The integrity of our sexual health and well-being should certainly be no exception in this group of women, and tackling it with new knowledge can minimize any negative impacts on your quality of life, emotional satisfaction, and the intimacy. That you have to tell her in a proper way. So we should remember menopause is the journey of recreating a balance and discovering new beginning in the relationship with yourself, because you should know about your body, how it is going to get changed, how it is going to be supported. It is only you can yourself look into it in a nicest way and get the gynec care And each and every gynec should be well educated about this part of the women's life, which is very importantly make her better in her quality of life at this stage, with a better intimacy and better relationship in the couple's life. With this word, I thank you one and all for the patient listening, and I'm open to the questions. Thank you.
Thank you so much, ma'am. Dr. Priyankur?
Thank you so much, Jairani ma'am, for that wonderful talk. I open this discussion to the house for any questions that that you may have. Sumati ma'am, others, if any questions that you may want to ask.
I would only want to congratulate ma'am on doing multiple things today, especially. She's been really, really busy, and we really didn't know whether she will have time to log in and do the presentation, and she really did so well. Thank you for that unrestricted.
I would like to tell you one thing, that I'm going for a, now we are going for an open dharna. We are planning to have for condemning the act in Manipur incidents. We are planning a women's forum, all the IDWA women's forum, and all the group from the government officials and all the societies, they're all coming there. At 6 o'clock, we are planning to have one dharna to show our, solidarity. Solidarity for this, gender violent if activity of on the women folk. So I'm just going for that also.
Thank you, ma'am.
So
it was a very
so
unrestricted, very explanatory and very exploratory evidence-based presentation. Thank you, ma'am. Thank you for spending that time with us.
Thank you.
Thank you, ma'am.
Thank you, Sumati. Thank you. Thank you. Thank you.
Thank you for coming.
Dr. Priyankur Roy, thank you so much for staying with us for the entire presentation. And it was a pleasure having you. Please come to Chennai.
Thank you so much, ma'am. It was my pleasure to stay with you all for the whole session. It was very enriching and enlightening, and I learned a lot from the session. Thank you.
Yeah, Chitrakala, can we take a photo?
Kundavi madam.
Yeah.
Video on pannunga,
yeah, Kundavi madam. Yeah. I'll take a photo. Is Chitrakala there?
No, I'm taking this. Image varala. Yeah, நான் எடுத்துட்டேன். நான் ஸ்கிரீன்ஷாட் எடுத்துட்டேன்.
எல்லாம் வந்திருக்குமா? Thank you.
Yeah, thank you.
Thank you.
Thank you.
Thank you.
Bye bye. Thank you for joining us. Let's have more PS1s and 2s and 3s. Thank you.
Thank you so much. Thank you for joining. I thank the Oxy President and Secretary ma'am for giving us this opportunity, because we learn a lot of things. We interact with a lot of other people, and I'm very happy to propose a vote of thanks, because it's just even though we are doing everything online, and but it carries a lot of information, a lot of message to what we can convey to our patients, and including our family members and relatives. So thank you, President madam and Secretary madam. I thank the chairpersons, Dr. Priyankur Roy. It was absolutely amazing, because to stay all the way for the presentation and actually give your inputs also. And the speakers, Dr. Deepa, Dr. Ramakrishnan, and Dr. Jairani ma'am, absolutely have done complete justice to the topic that was given to you. Very, very thank you. We actually learned a lot, and a lot of things are there unexplored, so we can counsel our patients much better. And I thank my co-convener, Dr. Sumati ma'am. Absolutely so happy to work with her. I always feel it's a teamwork, and everybody has a very important role to play. And we have been very, very happy to work with Sumati ma'am in coordinating for this webinar. And above all, Shield Healthcare Chitrakala, Dr. Prachi, who have actually been very, very helpful in giving us this platform time and again for conducting such webinars almost every day in the last few after madam took over as president. So thank you everyone. Wish you all a very happy weekend. I know we all have to show our solidarity for this Manipur incident, and let us just pray that everything settles down and let peace prevail all over.
Yeah.
Thank
you. Thank you. Thank you, Karpaga. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you.